Okay. So for those of you who are online, someone has their speakers on.
Speaker and microphone has to be off.
So everything needs to be on mute. Oh, that's horrible. I can hear myself. Is everyone in the room on mute? Just the one.
We've still got.
So apologies to those waiting online. We are just having a few little technical issues in the room. Have we solved it? I think we have. Fantastic. We will kick off then. So good evening, everyone, and welcome to the November meeting of the Health and Wellbeing Board. And thank you to those who have braved the wind and the rain to come in person to the council chamber this evening, but equally welcome to those who are joining us online, and hopefully that gives everyone the flexibility to join as fits their schedules. I know a number of people have clinical schedules as well, so thank you very much for joining us. Apologies for absence. I think we only have the one, which is from Judith Finley, which is unfortunate because it would have been Judith's final meeting as a member of the board, and I think it would only be right and proper to record the board's thanks to Judith for many years of hard work and service to the borough and to the board as separate from the council. And I think there are nods in the room, so if we could, Keith, record those formally in the minutes, and we can thank Judith for posterity there. Although I know there are other occasions coming up to do so. I don't think I have any other apologies apart from Councillor Mason for lateness, who's just in another meeting at the moment. There are no urgent matters. Does anyone have any declarations of interest they need to make? No. I don't have any matters to be considered in private. So can we approve the minutes of the meeting in September as accurate, unless there are any corrections that need to be made? I can't see any hands either in the room or online. So we'll take those as approved, and I shall sign those. Dan, if you don't mind giving your Health Watch update, I will sign every page of the minutes.
Thank you, Chair. Just to avoid confusion, the information in your packets is from Q1, and I will be giving a patient experience update on Q2. We reached 1,200 reviews for this quarter. 592 of those are from GP surgeries, Another 215 are from hospitals, and that's kind of where I'll focus on this evening's briefing. We start off probably with the positives from the GPs. So overall experience, 66% positive. Overall support, 80% positive. And then quality of that support was 89% positive from all respondents. Staffing attitude, we saw an increase to 76% positive, which is definitely the highest number I've seen in my time here. And then professionalism was 100%. Small sample, but nonetheless worth mentioning. Where we get into a little bit of the consternation, access to services. Again, people are finding it difficult to get an appointment within a 2-week time spree. So we saw 48% positive, 14% neutral, and 38% negative. It's definitely lower than it has been, but we're definitely looking to get that around 30% if possible. In regards to patient choice, where we saw the kind of strongest negativities, patient choice is built around preference of face-to-face and preferred doctor. So only 8% positive there with 76% negative. Moving on to hospital. Again, 215 respondents. Treatment and care was 83% positive. Treatment explanation, 79% positive. Support, 91% positive. And overall experience, 75% positive. What I would point out about the hospital numbers is they tend to shift around 10% every quarter. So the average is somewhere in between. So I mentioned treatment and care is about 83% positive. We're probably holding steady for the year at around 76, 77%. A couple of GPs received fantastic reviews, and always nice to highlight really positive care with really positive feedback. So Acton Lane Medical Center, Acton Town Medical Center, the Welcome Practice, and Jubilee Gardens Medical Center received our highest patient reviews for this quarter and for the last 6 months in terms of reviews. A few things I would like to highlight is this will be the last version of the current iteration of the patient experience report. We've introduced a new survey and new report, and we will present that in for Q3. We'll also be able to capture online feedback on online consultations, as well as mental health and other social services. A few things that just touch on that we constantly looking to improve and build upon. One is kind of patient choice. We're hoping to see that the options are continued to be provided, whether patients see their doctor face-to-face, online, or using phone consultation. And we just hope that that choice is made available to them. We are encouraging GPs to provide online training to their patients and to make that available, how best to navigate their websites and to use it as patients need it. And this isn't probably something anyone's not aware of, but something new for us to kind of Health Watch Ealing to just kind of promote. So we have a lot of patients come back to us, elderly patients, about having appointments prior to 9:30 in the morning. And obviously we would just encourage, where possible, to provide older people with appointments after 9:30 a.m. so they can use their free travel and just easier to access. That's it from me. I'm happy to take any questions about this information.
Great. Excuse me. Are there any questions for Daniel in the room? Sorry, yes, Simon.
So firstly, all right, I welcome the report and certainly the positive responses for the hospital services, and it's good to see the correlation between what Health Watch is doing and our own internal feedback. And I suppose in the context of how challenged the trust is day in, day out, it is quite pleasing to see that the positivity scores are being maintained at that sort of level. And also, I suppose I would comment as well. The way the Health Watch interacts and with patients in terms of the getting direct feedback as opposed to doing it all from servers. And I suppose that I wasn't quite sure what you were alluding to in terms of this is the last of this approach and what it might be in quarter three. So the question is, will we be losing the amount of sort of face-to-face interviews and feedback as part of it? Because clearly that's a positive aspect at the moment. And the second thing is I did pick up the recommendations around the trust correlating with our own internal reports and what our appropriate response might be, which we will certainly do that. So thank you, Daniel.
No, apologies for any confusion. So simply, we have dramatically changed the survey to make sure we capture more social services. And the new report will reflect that. The way we are capturing the data will still be the same. We will be in GPs and hospitals every morning talking to patients.
Great, thanks. And Anna.
Thanks, Chair, and thanks, Daniel. I think just a comment rather than a question, if that's okay. I'm just wanting to point out some of Daniel and Health Watch's really proactive work supporting us recently around conversations out with communities around vaccinations. I think it's something we don't always pick up in the Health Watch reports on here, but they've been doing fantastic, and I think calling it conversations without judgment, and just really out there in terms of childhood immunisations and COVID immunisations dressed as dinosaurs, which I feel should have been in the slide pack, Danielle, but just really wanted to say a big thank you, and it's really good to have that collaborative, proactive work as well through Health Watch. Thanks.
Thank you. And then there was Neha.
Thank you. So yeah, I really welcome the report, and it's really nice to see some of the positive news after all of the feedback we've had in the media over the last few months. But one of the questions I wanted to ask you, if you're changing the report, one of the values of the report has been that you can do longitudinal work. So over a period of time, see where the improvements have been and where there is still work to do. Can you just assure us that we're not going to lose the ability to do that with the changes that you're making in the survey?
Yes, I can. So I guess perhaps I have phrased this poorly, but yes, the new survey is about adding information, adding sub-themes and different dimensions of care, because it's predominantly about GPs and hospitals. And we just felt that healthcare goes beyond that. So it's important to reflect that and capture more information around how people are finding their mental health services, how people are finding their social services. But yes, GP and hospital information, as well as dentistry, pharmacies, all of that can be tied into previous reports. Just it'll look a little bit different, but the data will still line up.
Great, thanks you. And I've got VJ with his hand up online, I think.
Yeah, thanks, Josh. Thanks, Daniel, for that. Yeah, I just wanted just really a comment around the feedback you received from the ones who completed this patient experience around the modality and choice or the consultation type and their GP of choice, and clearly there's the scores were quite low from that perspective, and it's quite difficult to really sort of try and square this one, because on the one hand, as we come out of the COVID pandemic, GP practices are starting to offer much more broader modalities of access in relation to consultations, and that has to be balanced with respect to clinical appropriateness and clinical need as well, and so certainly we found that there are certainly greater efficiencies in terms of online consultation, telephone consultation, video consultation, in terms of managing the throughput of patients and the demand, but also then trying to balance that with being able to offer, the whole spectrum of consultation style and type. So it's something which in general practice we are trying to get right in terms of getting that proportionality and balance. And I think it will take time until we sort of get to a point that, in a sense, the dust settles in terms of how we manage this going forward. And in terms of the choice of GP, again, as everyone knows, the primary care workforce has changed over the last few years, particularly in relation to our ARS roles and the wider health professional types that work in primary care, and that default position that it's only the GP that can manage your health needs, needs a shift in mindset with respect to the public, and that we do have a wider workforce that is there to manage their health needs, and it's not only the GP.
Thanks, Vijay. Daniel, was there anything you wanted to pick up on what Vijay's?
Yeah, just last two. I would just like to say thank you, Anna, for again raising that. It was a pleasure to be a part of, and we love doing it. And we hope to work alongside everyone in the council and the NHS to do more like that. In response to Vijay, I appreciate that. I think sometimes the survey lacks nuance. And what I would simply state is, while there was 76% negative for preferred doctor patient choice, 89% rated the quality of the service they got incredibly highly. So they may be frustrated by that, but I do believe they're coming away believing that they got the care they needed.
Great, thank you. And then finally, there had been a question from Erskag, and I don't know, Roy, if Daniel's answers earlier about the revised survey answered those. I don't know, Daniel, if you've seen the question.
I did submit the answer to Keith earlier today, so I'm not sure.
Right, so Roy, I don't know if that you've had the answer already.
Yes, largely, yes. It's our question about the extension of the research basis is answered in terms of being more social care issues are going to be included. So the only other part of that is what other direct forms of engagement with social care users exist, and how will that be structured? And then also, I think there was a commitment from Health Watch to do an annual survey updating the reports on housebound people. That was mentioned at the March meeting last year. I just wondered if you thought about that further.
So in regards to engagement, we have our patient experience, we have our original research, and then we have engagement with the community and larger awareness. We are, as an example of the housebound, I think that's a good example of our commitment to social services. And I believe that the additions made to the patient experience report will hopefully capture more of that social service information and feedback. In regards to the annual survey of the housebound report, our intention is to stay up to date with that information and then present our continued findings on the integration of our recommendations. I have no details at this time as to what that looks like, but we hold fast on our commitment to the annual survey.
Great, thanks, Daniel. And thank you for the item. I don't think there are any other hands up online. I'm squinting at a screen in the far corner of the room. So Daniel, thank you very much, as always, for your update, which brings us to the next item, which is on the cost of living crisis, which we wanted to take, as it is obviously going to have a very big impact on health and well-being of the people of the borough. And I think Kieran is going to give us a presentation on what the council is offering over the winter.
Yeah, thank you, Chair. I'm Kieran Reid, the Council's Strategic Director of Strategy and Change. joined on the call online by my colleague Una McCarthy, who's our Head of Strategy and Performance and who's been leading a lot of our work. There's a short presentation which is in the agenda pack, but I know came round quite late, which I'll talk through, and very happy to take any questions the Chair feels we have time for. First slide just sets out the areas that we might want to think about in response to the cost of living, and I think the obvious point is that they're really broad: health, employment, energy, debt and money advice, food poverty, really wide ranging. And that, sorry, just trying to move. Sorry, you can tell I'm using a colleague's technology. Speaks to the fact that this is going to be a really wide-ranging issue for Ealing residents. I think we know from just media coverage that people across and quite high up the income spectrum will be affected. Even after the government's fuel policy over the winter, fuel bills will be on average twice what they were last year. So that will affect across the income spectrum. Sort of notwithstanding that and accepting that we won't, as local bodies, be able to mitigate the impacts, thinking about who will be most affected. We know the areas of the borough with the highest concentration of multiple deprivations are Southall, Acton and Northolt. And we anticipate that the types of residents most affected will be those at the interplay between low income or income poverty and existing kind of health conditions, be that long-term health, older residents, those with a disability who might be more vulnerable, aggravating factors to compromising on heating, compromising on diet, increased social isolation, all of those points. So in terms of the response and the approach we're taking locally, working with partners, and I would really emphasise that whilst I'm here speaking on behalf of the council, we would very much see this as a partnership response. We want to sort of build on some of the lessons of the way we worked through Ealing together during the pandemic. So thinking about what we as public bodies can do to provide and raise awareness of support pathways, making sure those who are most vulnerable, those who are supporting them, know about the support that's needed, but also to recognise that the community in its widest senses will be responding to the pandemic, and our role as public bodies will want to be to try and support them and go with the grain of their efforts to support the community. And I'll say a bit more perhaps about how we're trying to do that. To think about our ability, to target support to the most vulnerable, and I'll give some examples of that. And of course, to think about how we can provide support in a way that gives people dignity and respect. So one example of that would be kind of financial support, which gives people their own choice and discretion over how they use it and limits the kind of charity kind of aspect of that, and certainly provides support in a dignified way. So we've been meeting monthly with a range of partners, voluntary sector, health, faith, and
that would be wonderful.
Hello everybody, we're just pausing whilst the computer is coming back online from the administration of the meeting. We'll be back shortly.
Apologies for the slight delay as we tackled some tech issues in the room. Our main computer went down, but has everyone been kicked out of the meeting? I can only see you, Kerry.
There's still people on my line.
Just I can hear you.
Oh, fab, brilliant. Sorry, I couldn't see you, BJ, on our screen, so I assumed everyone was disappeared. So apologies again. Kieran, do you want to pick up where you were?
Thank you, Chair. Apologies, colleagues online. I don't know exactly when you lost us. Hopefully you got the gist of my point that we're trying to build on the ways of working we established between partners, voluntary sector, and critically working with the community through the pandemic. So our response is really structured on providing information and advice.
Dina, I think you are unmuted, if you don't mind.
The areas where the council is able to provide additional financial support to individuals and VCS organisations in the borough, and work we're doing to support and enable community-led warm spaces. There's lots of other work that's happening. I'm focusing in this presentation on the additional areas of our response, obviously not to say that other areas are not important. So briefly on the information and communications side, we've created what we're calling a cost of living hub on the council website. It replicates the advice, support, pathways that are available in those main areas of concern that I referenced earlier in the presentation. We're supporting that, as you'd expect, with the communications plan. So using our social media channels, using our forthcoming magazine around Ealing, which have a strong focus on cost of living and critically reaches a perhaps older, more print-based audience than our digital channels. The website can automatically be translated into the 9 community languages. And we've got a leaflet which will be going out next week with an initial run of 40,000 being distributed to libraries, children's centres, pharmacies, and indeed anyone else who wants it, to be honest, to raise awareness. And as you'll see, that's the broad structure of the cost of living hub. And that's just a quick screenshot of the leaflet. The boxes with language will contain a QR code to take residents, signpost it direct to the information in their community language. Again, that was one of the main, that signposting effect, one of the main developments I think we saw during the pandemic, and particularly thinking about where there will be vulnerable residents in the borough, areas like Southall, where English language may be lower. First choice form of communication. Also, we'll be publicising the council's helpline number, so residents can ring for support and advice to access those pathways. We'd welcome you sharing the hub, the leaflet, and supporting the communications activity, and we're happy to try and promote community activity that's happening on our channels as well. Been working in partnership with the advice service, with the credit union, with the food bank, and others. In terms of financial support, again, this is kind of zooming in on the additional offer. So the council is administering the council tax energy rebates. We have our local welfare assistance scheme. We've been continuing provision of the household support fund. So that's voucher support to those eligible cohorts. There, quite significant amounts of money distributed to those vulnerable households, and the again in the coming school holidays as well. As part of our use of that household support fund resource, we'd set aside £100,000 invited bids from voluntary sector organisations, recognising that there may be vulnerable residents. Whilst we're stepping in and trying to target those cohorts with the cash support, there may be others where VCS organisations have a better reach. And so we've had a number of bids in. We'll be making awards very shortly on that. I think colleagues are confident of having a good geographic coverage of across the borough. The VCS organisation successor will be providing things like in-kind support, food parcels, blankets, also signposting opportunities to the other advice that's available. I think it is possible that we don't have sufficient bids in the first instance to award the full £100,000. So we'll be looking at whether there are any other organisations we could support, whether there's a bit more of that resource that can be channelled to successful bidders. So look out for confirmation on who those organisations are very shortly, and happy in the questions, if it's helpful, to say a bit more about the profile of those who've received cash support. But I think if I start listing that now, I won't stop. Just briefly, knowing this is the Health and Wellbeing Board, wanted to recognise there is a strong kind of health and wellbeing presence on that advice hub, signposting residents to support advice pathways that may be available. And that's a dynamic resource. If there's something that your organisation provides that you feel should be on there, we're in control of the website. We can update that. Please just get in touch with me or another council colleague to signpost to me, and we'll be happy to do that, I'm sure. Finally, just on warm spaces, this is obviously an area there's been a lot of attention, particularly given the energy bills position. It's not a problem, I think, being honest, that we're in a position to solve locally. We've got a two-stage approach. The website will identify the council buildings which are open for the cohorts that they're open for. So that might be children's centres for younger families. It might be day centres for vulnerable adults. Libraries obviously are open and well used across the borough. We recognise that faith and voluntary groups are trying to step into this space already. So we'd introduced a relatively modest scheme, and I would start by saying that, modelled on a couple of schemes delivered outside of London in Bradford and the North East, where they'd provided grants of £500 to £1,000 towards any faith or VCS organisation operating a warm space. The conditions being the warm space is open for at least 4 hours a day, and its hours a week rather, and its existence is publicised on the council's website via a searchable directory on the community support pages. So we've upped that to £1,000 for existing provision, £2,500 where people want to introduce new provision. The format of that is entirely open to those organisations. It might be targeted at a specific group, a coffee morning, a film club for older people. We're not prescribing the model. It just needs to be open at least 4 hours a week. It needs to be sign up some basic principles, and it needs to be publicised on the website so we can direct the relevant users to it. And we will be looking to provide some wraparound support, some advice for our public health colleagues on providing that provision safely particularly from a COVID perspective, and possibly once that provision is up and running, directing other forms of support that might be, whether it's public service outreach, whether it's other community groups providing support, the council is enabling via one of its buildings a community groups running a clothing exchange. Obviously the locations of the warm banks will be something they're interested in finding. So absolutely wouldn't claim this is going to cover even the full costs of providing that provision, and we will try and monitor numbers and see whether there are opportunities to stretch and expand that provision. But it's the deadline for applications closes on Monday. We've received a number already, but absolutely really welcome partners on the call sharing it with their networks and encouraging bids to come in so we can make sure we do have a genuine network across the borough, limiting travel costs for vulnerable residents. So there's lots more I could say, Chair, but I'm conscious probably the value's in the discussion. There were some questions that we would welcome feedback on in terms of support we should be signposting to, concerns you might have, and really, the council can't do this on its own. It's certainly not claiming we are. We're proud of what we've done to date, but how can we work better with you? I'm very happy to follow up any new ideas that colleagues on the board might have. And thank you very much for your attention.
Great, thank you, Kieran. Maddie, do you want to add something from the public health point of view?
Thanks very much. Just to add, for the warm spaces work in public health and across the health system more widely, we're exploring a broader health and public health offer to those warm spaces that come online, develop. So that might include, as Kieran mentioned, some support to make sure they're following up-to-date infection prevention control guidance and working out how best they can ensure the safety in terms of infection spread of those who attend the warm spaces, but it could also include things like roaming officers who work on TB prevention awareness, health promotion in terms of blood pressure and other areas. There's also a Healthy Start officer who may well roam in and out of these spaces to promote financial assistance to get nutritious food for families and pregnant women. So the list goes on in that kind of public health and health offer. We're exploring lots of different things, ways in which we could add value to communities using those spaces and get additional kind of health and wellbeing support to a captive audience during the time they're there.
Thanks. And I think, hopefully this demonstrates the kind of the whole council approach to public health. And as I said at the beginning, cost of living is something that's going to exacerbate some of the inequalities that we know do affect people's health and well-being, and is all funded from existing budgets. So it's not something we've got additional resource from. So this is us making a political choice to invest in helping our residents through the winter. I've got Neha and Kerry to come in. If you are online, just pop your hand up. I will see you. So Neha.
Thank you. So just to update as well, from our perspective, from a health perspective, we've circulated the leaflets that have been created widely through our GP networks, community pharmacies, social prescribers, providers as well, so that if they come across anyone that could really benefit from any of the support and advice on the leaflet, that they know where to go to and how to access that, which is what we did last year as well, and other things as well. So that's.
Thanks, Kerry.
Thank you, Chair. And just to say, Kieran, we've been discussing this excellent work with a number of the partnership boards, and there's a lot of real interest from the partners and from people who use services about maintaining and developing the information that's on the website. So we'll update you with further updates from Mental Health Trust. We had a really good discussion this week with regards to the piece, and we're going to provide updates. So it's excellent work. Thank you.
Simon.
Couple of things. So certainly very happy to share the information on our website as well. So perhaps outside of here we could have an exchange in terms of what you'd like us to share. But also I suspect through our discharge hub, the link with the local authority, they're probably quite well cited on access to some of these. But equally, I suppose, our outpatients, our same-day emergency care, our specialty clinics, and urgent care and A&E. There's no reason why we couldn't advertise some of this in those areas if you want. And if you've got particular posters or leaflets that you want us to put in those areas, happy to do so.
Okay. I can't see anyone else online, but I'll go back to Kieran if he wants to come back on anything that's been said and give people online a chance to put their hands up.
No, just to say that's really welcome. We'll follow up with colleagues with links. There will be increasing collateral, posters, social media assets. Feel free to use them, repurpose them on your channels as we've done through COVID. We are seeing that work. So we have seen, since we really started the sort of publicity push on this probably in October, very significant take up in visits to the website, calls to the council's contact centre. Obviously, that's partly a reflection of the reality of the difficult, unfortunate situation that residents are in. But I think it also does show the importance of trying to signpost and get that kind of message out to people. So welcome. We'll follow up on those offers of support.
Great. Thank you. And I think it shows the value of collaborating with partners and bringing them together into this room physically in some instances tonight. And then, so to finally, Kerry, there'd been a question from ERSCAG on cost of living, particularly in relation to disability-related expenditures, if you wanted to pick that up.
Thank you, Chair, and thank you for the question, Roy. So the council, as per Kieran's presentation, the council's been working very closely with a range of partners to develop the information about the support that's available to local people during the significant challenges this winter with the cost and advice disabilities, and believe that they're going to be facing additional costs this winter, and that their disability related expenditure assessment doesn't reflect this. Then this should be raised with the finance department and request a review of their financial assessment. Thank you.
Thanks, Kerry. Roy, does that answer what you had asked?
Oh, thank you, Chair. I think I'd just like to reiterate that, I'm pleased about the council website highlighting some of these areas where the council can help, or other organisations can help. I think the warm spaces is quite important, but obviously some housebound or some people with severe disabilities need a warm space in their own home, and they are worried about heating bills and bills for electricity for charging equipment, etc. So I think we are a bit concerned that the disability-related expenditure having to be claimed after it's been spent and on a case-by-case basis is a bit difficult. I think we probably need something a bit stronger, really, about how perhaps there should be some sort of discretionary grant or financial input to help people who are facing these higher bills. And then just to add, really, that the council online hub cost of living advice needs to be expanded to deal more with the benefits, specific benefits and support available to people with disabilities. They're not really mentioned very much, although I'm glad to say they have been mentioned in the presentation. The only other thing I would say is that the closing date, the 22nd of November, is a bit short notice for organisations to get an application in at this point, given that the around Ealing information is going to be on the cost of living crisis, and that's not until December. So it's really perhaps this closing date should be perhaps lengthened or put back another month or two. Thank you.
Thanks, Roy. I'm sure we will continue to receive applications for as long as we need to.
Yeah, just really briefly on that point, we obviously wanted to get the provision in place as soon as we could, conscious it's getting colder, the days, nights are drawing in. We have advertised it in our electronic bulletin, which goes to 140,000 households a week, and also directly contacting the organisations, Faith and VCS, who might be most likely to provide it. We've had a number of applications. We'll obviously keep that under constant review. And just if I may, just super briefly, the gentleman raised the question about financial support. So there are a couple of schemes, but neither of which are exclusive to people with disabilities, but they are targeted at the vulnerable. So the council's administered energy rebate payments, £150 to just under 100,000 households. So they're being sort of passported through. And the council also had set a discretionary energy rebate policy, which targets payments to those on council tax support, so having trouble paying, recognised as being on very low incomes in the smallest house council tax bands A to D, providing an additional £66. So the council's total discretionary expenditure on that scheme's just under £2 million. Again, not exclusively for disabled residents and not going to solve the crisis, but targeting the available cash resources we have to the most vulnerable as we're able to identify them. Thank you.
Thanks, Kieran. And Kerry, I think you were going to come back on a couple of points.
Yeah, thank you, Chair. Absolutely, Roy, in terms of the advice and information and that being key to supporting people in the community during these challenging times. And we're working closely with Ealing Advisory Services and our partners within the NHS to expand and fund additional advice and support with Ealing Advisory Services. I think it's for at least to the end of this financial year to support more people access the support that's available to them.
Thanks, Kerry. So thank you, Kieran, and the team and everyone else for their work on this. Obviously, it's only the start of winter, so hopefully we will make a difference to some people over the coming months, which as I think, as we all recognise, are going to be very difficult. So thank you very much. We move on to social care update. I think there are some formal things to note in terms of the Better Care Fund. Kerry, were you going, or Anna, Kerry, I assume on social care update, we're going to introduce
Thank you, Chair. So this is the update on the Better Care Fund policy framework, which is we bring here every year for the sign-off and agreement and take any questions. Better Care Fund, as colleagues will be aware, is an ongoing framework that's been in place for a number of years now, which integrates and pools funding between the NHS and the council to support better outcomes for the communities that we serve in Ealing. The Better Care framework sets a number of metrics which are overseen by the Health and Wellbeing Board. These are rolling forward on the metrics that have been used in previous years around avoidable admissions to hospital. Obviously, that's a whole system issue that people are, that we as a system and council and NHS partners are very concerned about. Hospital discharges to a person's place of residence, so that's avoidance of admission into care homes, essentially. Admissions to residential care homes, which is the flip position in terms of the number per head of population admitted to care homes, and the effectiveness of our reablement programme in line with the council's Better Lives framework. Essentially, we're bringing the report here for information and to take questions from partners in the Health and Wellbeing Board. BCF, which is the improved BCF framework, is just over 12 million, additional LA contributions of 57 million and 8 million. So the quantum that sits within the BCF is 111 million. So this is a significant amount of money, and it really supports how we serve the communities in Ealing. And I think it's really important that we bring updates to the Health and Wellbeing Board in terms of the performance against the key metrics that are set out within the paper. So is that okay as an oversight, and then to take any questions, Chair?
Yeah, that's absolutely fine. I can't see any hands in the room, which is reassuring because everyone should know what the BCF is by now. And I can't see any online. Kerry, there had just been a question from Skag about some of the data underpinning the BCF and how we reach, I think, some of the numbers within it. I don't know if you can answer that, or Neha is happy to pitch in.
Yeah, so Neha and I have discussed this, and I'd be happy to meet with Roy outside of the meeting to get a better understanding of where he's getting to with the question. We don't think there are any problems within the BCF. We think it's a really positive piece of partnership working, but Roy, happy to sit down and go through your concerns and maybe bring something back here for an update after that meeting, Chair.
Neha.
Yes,
Sorry, Roy, and Neha was going to add something to that.
okay.
Yeah, just to add that, I hope that's better as a sound, but just to add that this is a yearly review as well of everything that we're spending in it, and we review our service schedules. There's a very clear intention of working as a partnership to solve those problems, and making sure we're looking at the data that is available to us, the metrics that NHS England and national bodies ask of us, and then adapting and tweaking to make sure that we are in line with what is required is a key part of it. So hopefully that should assure you that actually we stay on top of this one.
Roy, I think it might be best to take this one offline to discuss separately with Kerry. So I think that we could get here all night. We'd be here all night in terms of some of the details. Is that all right?
Yes, I just want to be reassured that we are keeping relevant information and collecting the relevant data, and that then we're comparing that year by year to look at whether we are helping with avoidable admissions to hospital, getting better at hospital discharge plans, etc., as Kerry has mentioned. But we may be able to take up this offer of a meeting and go through it in a bit more detail.
Great. So I think, yes, the answer is yes in short form, but yeah, let's meet and get the longer answer as well. So if everyone's happy to note that report, we can move on to the borough-based partnership, which will be Neha.
Thank you very much. So this is our regular report to the Health and Wellbeing Board. As you will all remember, the Borough-Based Partnership is operating following the implementation of the Act this year, earlier in July. And as a borough-based partnership, actually, we've been meeting for quite a few years, sort of getting ready for this more statutory approach, and includes a number of the partners that are at the table today. And this is the regular report of our latest board that we had in October, that is co-chaired by Dr. Vijay Taylor on the call, and Tony Clements as the chief exec of the council. So it's a very much a joint partnership. The items on the partnership this time are on one of the slides that you can see, and that ranged from how we operate collectively as a partnership in our governance and decision making around quality, finance, what our risks, collective risks might be, and we're developing our risk register in detail, but some more detailed conversations about the population health and inequalities subgroup of our partnership, and we have 5 subgroups, and we're doing a round, and each of those partnership boards is doing a deep dive on each of those over the year, and this time it was population health and inequalities. But in addition, areas that are in particular of issue for all of us as a partnership, for example, planning for winter, which is a real critical issue for this year in particular, but we do this collectively on an annual basis anyway. But this year we've taken a really detailed approach at doing this as a partnership. And there's a paper later on which I'll go through in a bit more detail. I'm sure partners will feed into that as well. So happy to take any questions on that.
Great, thank you. And I should thank you for the engagement meeting a few weeks ago, chaired by Chris Hilton, which was really helpful as part of the work locally on that. Any questions from members on the work of the BBP? I can't see any online either, so I'm sure we'll come back, as you say, to items like the winter planning very shortly, in fact. So thank you very much. Anna, Health and Wellbeing Strategy Update, please.
Thank you, Chair. I'll just do a very brief introduction. So Maddie and Roxy are here from our team, who have been leading this work with a lot of people involved in it through our steering group and our engagement recently. So a big thank you to everybody. This is really just to bring an update on the progress and a very, very initial flavour of the kind of things we're hearing from all the feedback through lots and lots of different routes. So it's very early days to show it, but we thought it was important to bring it here because we're at that stage where we're just really pulling it all together. And then in terms of forward plan, we're going to bring the report back to March for sign off. So we need to have a think what we bring in January in terms of kind of rather than a draft of the paper, a bit of a flavour of the principles and the commitments that we're putting in there. But I'll hand over to Maddie.
Thanks, Anna. So I'm just going to talk you through the process so far. Much of this will be familiar from the last update, but as you will be aware, we initially took a stock take of the previous strategy that ended technically in 2021. And the process for this was to do various interviews with stakeholders to get feedback on the previous strategy, the approach taken, and any learning from that process so that we could learn and build on the learning from that into the next 5-year plan. We next did, mindful of the wealth of information that communities and wider partners had already provided to us as a system that was relevant for health and wellbeing, we undertook an analysis of the various key consultations reports that were already existing, including the Race Equality Commission, Shaping Ealing report, a report from Voices of Colour locally, the Digital Exclusion Survey, Youth Survey, Women's Safety Survey. And we grouped the learning from all of these reports and processes into themes, just to mention that that's not an exhaustive list of everything that was looked at. That gives you a flavour of some of the things that were included. The next stage of the process in the middle of this diagram has been to fill some of the gaps in consultation and engagement. So to speak to specific communities about health and wellbeing, including facilitating willing groups who wish to run their own focus groups on the topic to do so. And in addition to this, to ensure that there was an opportunity across the whole population in Ealing, albeit a virtual one, to feed into the strategy, we had a survey online live from early October for a month. Moving on to the next section of this diagram, we're also lucky to have a wealth of evidence, national and regional literature on best practice approaches to addressing health inequalities, much of which is based on a kind of place-based intervention or approach. And we're using this body of information to ensure that each commitment as it's developed in the new strategy then has can recommend the most evidence way forward to improve health and wellbeing. And of course, all of this process has been overseen by a health and wellbeing strategy steering group, and that will run until it's published in March. And we, of course, come to this board to bring you updates. So I'll just hand over to my colleague Roxy to take you through this slide, outlining some of the more nuanced engagement that we've been doing to fill some of the gaps in the previous consultation thematic analysis.
Thank you, Maddie. So just to say a little bit in more detail, we had 697 responses to the online survey that closed last Thursday. In terms of the community conversations that we had locally, we visited the Egyptian traveller site in Acton, and we spoke to people living there. We had resident conversations as part of the Northolt Travel Scheme engagement in Northolt Library and Northolt Leisure Centre. We also attended a Poverty Week event organized by the Southall Community Alliance, where we spoke to local residents. We also attended a mom and toddlers group and the 50+ Caribbean support group at the Acton Gardens Community Centre, and the NHS Ealing Residents Forum last week at the Ealing Town Hall, where we spoke to local residents attending the event. In terms of a few of the focus groups that we had one run by Mind Food in Ealing. We had a focus group last week with about 60 representatives of the Let's Go Southall community. We also had an event organized by our colleagues in AHCVS at the West Ealing Library with service users and asylum seekers. And a focus group with two groups of drug and alcohol service users, one a Polish group and an English-speaking group. And we're also having one focus group organized next week at the Bollowbrook Youth Centre with young people. So just to give you a flavor of the very first insights we got from the engagement, just because it just ended last week. So we're still analyzing all the data, but you can see on this slide very early feelings of what we think might be the commitment, although they will change in the future, probably be a bit more articulate. And after we have the workshop in December, will probably be more changes to them. But so far, we think that one of the most important things coming up is enabling local community wealth and capacity to thrive. And just to give you a little bit more of detailed examples of what we mean by this. So what we've seen from the local conversations with people is that they feel that local organizations and the support they give to them is vital. They really appreciate it, and they the need, a lot of people spoke about the need of being heard, being understood, being included, and a lot of these small local organizations provide this for them. A lot of people spoke about local support groups that they used to attend and they don't have access to. A lot of these stopped because of the pandemic, and I think are coming back, but a lot of them haven't come back yet. So I think there is a need of that in the local communities that we spoke to, and also people wanting to give back from the support that they get by volunteering locally. So I think this aspect, this area of enabling local community wealth and capacity to thrive is around possibly supporting skills development for these organizations. The other area that has come out as a possible theme is supporting the use of local spaces and assets. So when speaking to the local people, just to give you some concrete examples, I think because we went around a few areas, we've noticed a very strong connection that people have to their local areas. I think I live in another borough in London, and I don't think I've seen that so much where I live. So I think it's a very strong identity that people have with the places where they live in Ealing. And I had, for example, someone say to me that they would like to see their local area more elevated, like things like if I go around, I want to see a little bit more signage about where I could go around and have a walk, more facilities in terms of things like having somewhere where to use a toilet, a public toilet, and also opportunities to socialize. So for example, I had someone say that they had a social club locally that they were joining on a regular basis, but the building was closed and they couldn't, that social club wasn't happening anymore. Or someone else said to me that they would like more affordable local venues where they could meet with the people. There was someone in the Let's Go Southall community that spoke about a group that she was running, a group called Let's Talk. And she said it was very popular, especially during the pandemic. I think she was splitting it into smaller groups. And she said now it's not so popular because it doesn't have a social aspect to it. So people spoke a lot about socializing all these areas where they could meet for various, support groups. I think those would be some of the concrete examples in the first two possible themes. I'll pass on to Maddie to speak a little bit about the next ones.
Thanks, Roxy. So to pick up the area 3, enabling inclusion through structural change, this as a theme that we've heard and read about through the engagement process, whereby people were talking about addressing structural discrimination and bias. Of course, many examples of this have been brought to light through COVID and with the Race Equality Commission. But another example might be that we heard from members of an Irish traveller community of various examples of everyday discrimination in supermarkets, in soft play areas for children, in the fact that they don't receive the same postal services as other communities. And these were all ways that they experience an impact on their health and well-being. So just really highlighted the kind of wider facets of life that can impact on health and well-being if you're on the receiving end of a discrimination at a societal and more local level. And another example of this area might be that we have noticed through the reports that have perhaps picked up on some of the feedback during the pandemic, but of course in ongoing work on vaccine equity, in ongoing conversations through this process, that people want to be engaged with through more nuanced points of trust, that authority and trust sit in different places for different people. And so we as a system thinking about enhancing people's health and well-being need to understand where those points of trust lie and really work with those points of trust that get to more nuanced community groups and get to some of the community groups that experience some of the worst health inequalities. Just to speak to area 4, so harnessing the power of anchor institutions. This really captures the power of these employment institutions have to influence and enhance local community wealth and therefore health well-being, albeit through providing assets for community use, their buildings, etc., or whether it's training opportunities for local communities, expertise and access to their networks. So we hear about harnessing the power of anchor institutions in national and regional literature, of course, all the time, but it's really coming through from local stakeholders, local partners and local people, that they want to see institutions that have deep roots into the community, using their power and influence, using their own assets, and also taking on that responsibility that they have to address the health and well-being of their workforce and their workforce's families and wider communities. The 5th point speaks to the issue that we've heard and read, the ask for and importance of co-production, co-design and working with rather than doing to communities. We've also heard the need for health and social care and wider welfare system of the council to work at a 7 towns level in Ealing. So this goes back to an element of Roxy's feedback, including having data at a 7 towns level, having local partnership working at a 7 towns level, and having assets and support from the system at this level also. And the 6th point links to that one, really a theme that's coming through around us as a system for health and well-being, having a deeper shared understanding of our local communities, how to better do the all-important work to listen to and have a dialogue with communities about health and well-being and the things that are in the wider context that affect health. So housing, finances, green spaces, etc. So we really heard the importance of having continuous dialogue, a two-way conversation, and how this should feed into the ways that we have stronger partnership working on health and well-being also. So that gives you hopefully a flavour of some of the insights from all of the intelligence gathering, and that goes right back to the stock take, the thematic analysis of consultations, and the more nuanced kind of filling the gaps engagement work that we've been doing recently. And just to mention some of the reasons that we took that approach to go specifically to particular communities or voluntary sector organisations was because we were conscious of the huge consultation fatigue out there in the community, and that we really needed to recognise that we already had a huge wealth of information from people that should inform this process. So the more nuanced engagement activities, those focus groups and those specific populations were to try and fill some of those gaps in what we already knew, but recognising that we did already know and had already been provided with a lot of feedback from residents, which was highly relevant. So just to end, this is the strategy timeline, give you a little bit of an update. We're doing this all important analysis, the intelligence at the moment, and bringing the content of the strategy together. We have a health and wellbeing strategy workshop with health and wellbeing board members, plus a few additional colleagues coming into that space on the 7th of December, which will be when we can bring much more of the analysis and of intelligence together, present a sort of draft version of what we think might be some of the commitments coming out of the process. And that will be really workshopped on that day, so we could get to have that really important discussion about what members of the Health and Wellbeing Board think about those commitments and how we can enhance and develop those. The strategy is due to go to Cabinet in February and will be published in March, so being brought back to the Health and Wellbeing Board for final approval at the March meeting. I'm happy to take any questions. That's it from me.
Thank you to all three of you. And I can't see my online list just yet, so if there are any questions in the room, happy to take them. But if not, I can't see anyone online at the moment. So thank you to all three of you and to everyone else on the team, and we look forward to the workshop in December. Which brings us to the winter plan update. Neha.
Thank you very much. So this is quite a detailed set of slides that we've circulated around, but it just gives you the scale of the conversations that we've been having as a partnership. And I'm sure some of my colleagues who have been a part of putting this plan together will add as we go. I'm assuming people can see it. I can't share my screen. Is that okay?
We are just getting them up on the screen for everyone, but if you kick off, they have been circulated.
That's fine. Thank you. So just to give a bit of context, every year, winter seems to last all year nowadays, actually. The last few years, it really has felt like that. But this year, there is a real concern about how tough the winter is going to be for all of us. And you've already heard of some of the work that's happening around cost of living, etc. But we just there are lots of other issues that are very widely shared in the media around staffing and how tough it is and how morale is quite low, but sickness rates of various different disease areas or just infections that are just creeping up. And if we're modelling based on what happened in Australia, then the flu season potentially is going to be quite difficult. So starting and making sure the flu vaccinations and all the vaccination programs are really doing well and started as soon as possible is really critical, and that we're targeting the right populations that are vulnerable. But in addition to that, it is really critical that as a partnership, we work really closely together with all of our providers and the community to get the correct messages out there to our local populations and the public, but also to all of our staff, and coordinate our responses across all of us as partners. And that includes from the hospital sector, social care, primary care, community, pharmacies, the voluntary sector. Everybody has a role to play in supporting us. So this year we started actually quite early on in the year, starting to plan, knowing that it's going to be quite difficult potentially. So back in May, we started to have the conversations as a partnership and put our brief early indications of what we think we needed to put in place locally, and then had to wait until it was confirmed how much funding was coming down the track to then firm up the various schemes, which is what this pack describes. The schemes that you've got in front of you in this pack. So on this first slide, it just gives you a bit of a context of how we work on winter planning every year, and that the budget comes from various sources. And given the pressures, we've had additional budgets from the Northwest London ICB as well for the whole system. And I know all of the acute hospitals and local primary care, local authorities have all been working really collectively together to make sure that we're all answering the questions of winter this year. I'm going to move on to the next slide. And the next slide, just at the top, you just have some principles of what was asked of all of us from the winter planning scheme. And one of the things I think is really important is that the intention is that although this money is coming down, we've got to monitor this as we go along throughout the whole of winter. And if things aren't working as we expected, or we need to do something slightly different, that we use that monitoring activity to then tweak our services and what we are putting in place and where we're putting the additional investment. There are a number of risks associated this year with staff morale, but there are specific risks for each of the schemes that are described here in the different sectors of the health and care system that we're working in this year as well. So some of the activities in the acute sector, so Ealing Hospital in particular, but also all of the hospitals that surround Ealing, because our residents do go to all of the hospitals around Northwest London and wider at times, have been having similar conversations and looking at the bed capacity, increasing the number of beds, but also that flow out of the hospital and ambulance intakes as ambulances arrive at the front door, to make sure that there is a reduced handover and really good communication between LAS crews and emergency department sites, but also then working on specific pathways around frail patients or homeless or children. So there's a lot of work happening across the system. The next slide just describes some of the risks in particular, but there are also some really innovative programs that are happening around pathways about, so when a patient gets discharged from hospital, if they live on their own, working with organisations like Age UK to then settle them back at home with support, and say if they need fresh food or something, just to make sure their heating is on and that they are safe, so they don't end up going back in hospital because of unintended consequence. So working with our voluntary sector is really important, and the hospital's been doing a lot of work on that, but also working with the community transport services about seeing if there are other flows, and to support LAS, not for those that need emergency transport, of course, but for lower level where somebody just needs to come in, they're vulnerable, they don't have any transport means, but they need to just come in for, say, a test for a few hours or monitoring or whatever that is. So there's lots of pathways that are being developed. And obviously some of the risks are set out there for the acute hospitals. If you go to the next slide. The next slide talks about mental health programs, and as you will all have seen, there are a lot of patients presenting in A&E with mental health, but also other settings, and doing more work around increasing capacity of the crisis and assessment teams, the single point of access, and the mental health safe spaces. But also people like the addiction, increasing the addiction liaison worker capacity as well. And again, those risks for mental health teams are listed there. And it's important that we're just cited on those and we have plans to mitigate as far as we can. And this is a very ongoing live agenda at the moment. If you could just go to the next slide. The next slide describes some of the schemes that are happening in the community sector, community services sector. So our additional beds at clay ponds to reduce the length of stay in the hospitals and improve the patient flow. So anything we can do to help patients discharge out of hospital to the right setting with the support is essential. Frailty virtual wards is something we're looking at with potential of quite 15 beds coming online soon, which is people at home with support and just checking in on those individuals with specialist support around them, and rapid access services as well. And then in primary care, there is a specific schemes where we have commissioned additional capacity from our GP sites, and we've got a few sites. So we have 3 sites at the moment that are operating around Ealing that provide additional capacity on Sunday and ready for bank holiday provision. And then we've asked them to increase that capacity on Saturday evenings, every evening, in particular to support 111 redirections and urgent treatment centre redirections as well. We are just going through an expression of interest process because that's only up until March, just to make sure that we've got the GP practices. It looks like we're going to go down to 2 sites, but with increased capacity at those 2 sites, serving the whole of Ealing during those additional times. And that will help again with the pressure on the acute sector as well, and the flow of patients. And then the final slide picks out some of the work that we're doing with the local authority, and then additional work around the voluntary sector, which Kerry also already mentioned around the Ealing Advice Service and the additional capacity for that service, but also additional capacity for social workers working 7 days a week to support the hospital assessments and discharge processes where they're needed, and reablement capacity. And a new initiative which we're trying out this year is about trying to support patients to be discharged sooner, but with reablement support organised by the local authority and the reablement capacity that's already in place. I'm happy to take any questions, but I'm sure my colleagues might have more to add on any of that. But there's just a lot of work, and we'll be keeping an eye on it.
Thank you, Nehal. That's a really comprehensive summary of all the planning. I suppose the question is, there are a lot of risks in there, and there's always risks. But I suppose the big question is how likely any of those risks are, given the pressures on the system at the moment, and how likely it is that we'll be able to mitigate against all of them.
So, to be honest, some of those may well come true. There's a lot of planning happening nationally, but at the North West London wide level, and we've learned through the COVID about everybody across the whole of North West London supporting each other and If, say, ICU capacity at one hospital is full, there is transport arrangements to another ICU in Northwest London. And I think that's the power of working as a collective across Northwest London. And there is a lot of work and thinking and scenario planning happening at the moment as to, if those risks do come true, how would we respond as a collective, as a partnership across the whole of Northwest London, not just Ealing. And we will be stepping up as needed. We had a Gold Command structure in Ealing where we were meeting on a very regular basis as senior leaders in the partnership to unclog things, understand the risks, escalate them, and try and find those solutions.
Thanks. Simon, I know you've got winter update on your later update. Do you want to come in now? And
yeah, so all I was going to say is maybe going forward, we ought to give some thought to doing a combined report on aspects of it, actually, because I think it'd be more helpful for the committee if we were able to do that on certain things like winter plan, where all the partners are working together. It needs to be probably one document. Well, when we come to ours, we'll talk about some of the additional mitigations that we're putting in this winter that we haven't put in previous winters, and we'll talk about those in a second. But I suppose the ultimate is if we talk about pressure on the hospital for emergency admissions, ultimately we would be looking at stepping down other activities. So the reality is that we are fighting really hard at the moment to continue to deliver the elective, the planned diagnostics, the planned outpatients at an increased level to what we were doing pre-COVID, and we're doing that pretty successfully. But there comes a point where if the emergency pathway keeps flooding through the door like it is, and it goes higher and at a greater level than what we're forecasting and our mitigations are at the moment, then we would have to consider reducing elective activity that would free up surgical beds that we would then use medical beds for the take. So that's the ultimate backstop. It will impact on elective and planned activity in response.
thanks. Oh, Kerry, did you want to come in?
Just to mention, in Neha's really helpful report, there's reference to the additional 500 million that's been discussed at national level. And this is the coffee money that was promised 2 months ago, I think it was.
Health secretaries ago, I think.
Yeah, it feels like that. So we're still waiting for confirmation on that. And we've got plans in terms of as and when, and if it does become available, how would we use it to the best output in not only in Ealing, but also across Northwest London.
Thank you. I don't see any other indications. So Neha, thank you again for the very helpful update. And I think we go back to you for the autumn vaccination programme update.
Thank you. So I haven't sent any papers in for this because this is, as you know, a changing environment. I mentioned vaccinations earlier in when I was talking about winter and how important it is. So just to give a bit of a brief on the various schemes that are happening at the moment. As you all know, we have the COVID booster program happening at the moment. The latest vaccination uptake rate for autumn for this year is 9.2%. But we've really targeted housebound and care homes in particular. So our most vulnerable residents in the community are vaccinated as early on as possible. The vaccination programs, the sites there are 15 community pharmacy sites which we've been running for quite some time. So I'm sure people are very aware of them now. People can book their vaccinations through the national booking system. And we have our roving team, which is going out to various settings like St Mary's Hospital, and we're working in partnership with Mattock Lane Pharmacy, for example, as well. And the adults over 50s, carers and healthcare social workers, and those that are in the at-risk clinical groups are all open to get the COVID vaccination at the moment. Just a brief update on where we've got to with polio booster vaccinations. The program is continuing. The offer for vaccinations went out to all 1 to 9 year olds by the 26th of September. as was planned. That's about 45,000 children registered at our GP practices. We've got, although the booster uptake numbers are low, we've got the highest uptake as a percentage of Northwest London at 13.2%, which is about just nearly 7,000 children. And CP House is still open, although it was meant to close earlier at the beginning of autumn. It's still open, and it has vaccinated about 1,366, and they are also operating the roving team as well. Some other key programs, MMR, there was a centrally managed call and recall process by NHS England for all 1 to 6 year olds that were overdue or eligible for their MMR vaccine to try and get those rates up. Ealing is currently for the 24 months at 89.7%, and for the 5-year MMR second dose is at 80.8%. In addition, the flu vaccination program has it's running in full swing, being run primarily by general practice and pharmacies, and about 14% of our population has received the flu vaccine. But however, we think it's a lot higher than that, because we've got a bit of a data issue, but we think it's a lot higher than that. And then monkeypox, as you all know, there have been a few cases across London, and the vaccination program is being run by our sexual health clinic. The only other thing I would add is if we have any asylum seekers or other communities that are arriving in the community in the borough, we're working collectively to try and identify where they are and get the vaccine to them as soon as possible.
Great, thank you very much. I was going to ask about monkeypox, so you've already ticked that one off. Are there any other questions or comments from members? No, can't see any. So Simon, back to you for the London Northwest.
Yeah, many thanks. Can we pull the slides up? Thanks, Keith. So Joe Paul will take you through the operational performance challenges and winter plan. So that's the first part of the slides. Then I'll pick up on the current and future investment plan and developments, and then I'm going to give an update on where we've got with our trust strategy development. Probably say fairly similar things around the engagement process as you've heard around the council strategy. But if I can ask Joe to kick off with where we are in terms of operational performance, which I think you'll see in the context of the challenges that we're facing is pretty good at this point in time. We'd like it to be better, but we are certainly moving in the right direction, or have been up until this point in time, as we get into the thrust of winter. But Joe, over to you.
Joe, we can't hear you. Although you were unmuted. Do you want to try again? Still can't hear you, I'm afraid. I don't know if you want to drop off and try joining again, if that might help. I don't know if Simon, if you want to cover the strategy bit.
Go on then. I'll cover the other bits and we'll come back. But if Joe's not back, then clearly I'll do it. So so in terms of the investments and changes since April of this year, the trust has a good track record in accessing capital funds and being able to spend that in years. So we've got a fair degree of confidence within the system that if we get capital, we'll spend it appropriately and deliver the schemes to plan. So we've delivered a number of those So the first one in April talked about LAS postcode redirection to Ealing. So that wasn't a capital scheme, which is what threw me. But so it's investment and changes. So given that the ongoing pressure at Northwick Park Hospital, and the pressure there, one of the things that we agreed with LAS was a redirection of the postcodes just north of the A40 in terms of Northolt, redirecting those. The first port of call should be to Ealing rather than Northwick Park for those. That's been enacted. It's the investment and service developments is April is the first heading there on the slide. So that's been acted and is routinely operating now. There are other changes when Joe talks about the winter plan, or I'll come back to that afterwards. We upgraded the endoscopy suite on the Ealing site, so that's now fit for JAG accreditation. So that's good news. We commenced the upgrade of IT infrastructure of the site. That's a lot of investment in the Wi-Fi, the infrastructure of the site, because one of the other big things that we will be doing, it's mentioned from October onwards, is that in August 2023 we are due to go live with the Cerner electronic patient record system. So that will put London Northwest on the same platform as Chell West and Imperial, and then Hillingdon, we're doing a joint implementation with Hillingdon. Hillingdon will take the same system in October 23, and that will make a sea change in clinicians' access to medical records, and it will also make a big difference into the operational efficiency of our clinicians. In May, we also replaced one of the CT scanners on the site, and June the replacement of the MRI facilities. In September, and I think we had the mayor come and open it, the new replacement cardiac cath lab was opened at Ealing Hospital. And so up to this point in time, we've spent in the order of £5 or £6 million in this financial year on the Ealing site. There's further investment to come. We're currently reviewing the configuration of the Ealing theatres and critical care capacity and expanding our recovery unit from 4 to 8 beds. I've mentioned the Cerner system going in. The next slide is a comment around the emergency department. So Ealing clearly is a DGH providing the full range of A&E emergency response. It's an undifferentiated take with a busy urgent treatment centre, and the reality is it's quite constrained at the front end of the site. So we are reviewing how we can improve the layout and the scale of that environment at the front end of the hospital. So we have seen growth in attendances at Ealing and at Northwick Park, like the rest of Northwest London. So it's really important that in forecasting demand going forward, to being able to maintain infection control and also to support the impact of increased mental health presentations into the unit, that we review the layout and consider what good looks like for the service going forward, and recognising that there's a continued expansion of the population in Greenford, Hanwell, Northolt, Southall over the next 5 years. So that's a key piece of work. We're looking at what we could do here and now over the next 6 to 12 months in the environment, but we'll also probably think about a bigger piece of work going forward. The next slide then talks about the Ealing Community Diagnostic Centre. I think most of you will be aware that there was a temporary facility on the site in terms of small community diagnostic MRI scanners there that are currently run by Imperial. The plan is to significant part of national policy to significantly increase access to diagnostics. So London Northwest has been awarded in the order of up to about £30 million to invest in a new community diagnostic centre on the Ealing site over the next 18 to 24 months. That would include 4 ultrasound rooms, 2 CT scanners, 2 MRIs, a DEXA scanner, X-ray, phlebotomy, etc., as you can see on the slide. We have appointed architects and a design team. We have been out to 10. We are in the process of doing all the design work to enable us to go out to tender in February. We will be incurring all the design fees and the workup costs in this financial year, as well as potentially sort of clearing the area where we're likely to put it in terms of getting that fit for the new construction taking place in the new financial year. And the intention is that it would go within the old maternity, well, the new but old maternity unit on the Ealing site. Then longer term, as I've alluded to, we are undertaking a complete review of the site, recognising that Ealing has played an important part in response to COVID. It's a critical part of London Northwest. It's a critical part of the DGH hospital facilities in West London, and therefore it's time to reflect what good looks like for Ealing Hospital in the longer term. So we are looking at the potential for increasing some of the surgical capacity on that site. A particular pathway we're looking at the moment is around gynae. And also thinking about the partnership working and some place-based supporting delivery borough-based services potentially on the site. I've alluded to the community diagnostics centre being there, and we will be looking at the commercial opportunities around similar sorts of development around an energy centre and car parking that we've undertaken on the Northwick Park site that's been quite successful, as well as looking at housing potential. So we will work closely with the council in terms of looking at development control plan for the site and what the possibilities are of that going forward. Happy to take any questions on that in terms of the investment over the last year or this current year, and what we're planning to do going forward around the site and the services. Or I'm happy to move on to strategy, and then we can come back to Joe.
Any questions on that part, Anna?
Thanks. I mean, just one quick question. What's an energy centre? And just thinking in terms of links with sustainability on, redesigning such a large site.
Yeah, it absolutely does link with sustainability and more efficient energy production. We've significantly reduced our carbon footprint at Northwick Park as a result of the investment that we've made, and additionally, in the longer term, it will save us quite a lot of money. So it absolutely would be part of that sustainability agenda in terms of taking that forward.
Presumably, would link with any housing developments as a neighbourhood.
Yeah.
Combined heat power type centre, which would be really good. Thanks for that. Just before we move on, I think it's so good that we are having a conversation now about investment in the site and new service in the site, which is so different from, I think, the conversations we've had in the past. So, growing the A&E at Ealing is a fantastic place to be. So I think let's recognise that, and thank you for listening to the community over the years and keeping that one open and in fact expanding it.
Just I haven't referenced a particular phrase. That was then, this is now, we're going forward in a different direction.
Brilliant. Speaking of going forward, do you want to cover the way forward?
Yes. So recognising that our previous strategy was written in 2017 for 5 years, so 2017-18 to 22, and recognising that we had a new chief exec chair. We're working as part of a new acute collaborative. It was time to refresh and redo our strategy for the trust. Although clearly we've linked with the acute collaborative and the ICS in terms of making sure that our thinking is aligned. And so we've all been through a similar process as the council alluded to around his, in terms of making sure that we are engaging big time or have engaged big time in terms of reaching out, in terms of getting staff feedback, getting community feedback, getting patient group feedbacks, and the latest stats I think I have is that because we've closed it now, I think at the time of writing it wasn't, but we heard from 781 community responses, over 2,218 of our staff, which is nearly over 25% of our staff. We had 96 independent forums, 64 for staff, 32 for stakeholders, and we organised 3 stakeholder events, one in Brent, one in Ealing, one in Harrow, particular journeys of the development of the strategy. And thank you very much to the council for facilitating that here in August. It's unfortunate it's a particularly rainy day in the middle of a hot summer, so that impacted, but still, in terms of those who attended, it was very helpful in terms of getting some of the key thoughts and messages and sharing where we'd got to with the strategy at the time. And what came out of it at that point was around the need to reduce inequalities, inequity in terms of access to services, the need to focus on being very outward reaching in terms of local employment, making it much easier for us to recruit local people that reflect the population that we serve, and in particular for lower bands. You know, NHS jobs is not the easiest system to use and intuitive, and it's certainly, if it isn't your first language, it's particularly difficult as well. So thinking about different way of recruiting locally, thinking about access to apprenticeships and supporting people into work. We must get the best from the resources. Part of this is about recognizing the value of some of our corporate and our administrative and our supporting services, the frontline clinical. You will know the organisation has been financially challenged for many years. That means you invest in frontline clinical services, take out of the back office. And I've already alluded to the fact that one of the big impacts for us would be an improved clinical information system. So recognising that to deliver high quality clinical services, you need high quality support services to make that happen. And I think that's something that we haven't necessarily done in the past. And clearly, again, one of the other things is around pathways into services and signposting and communication, so improving access to services. There were 10 key themes. I'm not going to run through all of those. They're on the slide. Happy to take any questions. I've reflected the fact that we had the Ealing Town Hall event. Again, happy to pick up any questions on what came out of there in terms of what we heard from the Ealing Town Hall event, what was missing at the time. But I'm going to move on to in terms of where we've got to. So the what next at the time the slides were written and following the Town Hall event were that we need to consider what we'd heard in terms of the messages we'd heard across all the forums, and where we are currently is a recognition that we're going to put quality at the heart of everything we do. The trust values are our heart values, but we're going to put quality in the heart of it. And so there are 4 key areas we're going to focus on: high quality, timely, equitable, and sustainable care, and access to high quality, equitable care in a sustainable way. High quality employer, making sure our staff feel belonging, part of the organisation. We're quite good at recruiting. We're not so good at retaining some of our staff sometimes. And so a focus on retention. High quality and responsive and seamless support services that I've already mentioned, and obviously part and parcel of being here today is reflecting the high quality partnerships that we have. We're not an island. We need to work more effectively with each other to deliver the best possible care to the population that we serve. And what will that lead to is key objectives against each of those priority areas, along with the timeline for some of the key actions that goes with that. So that's where we've got to with the strategy. A draft of that went to our executive group this morning, and it will go to one of our executive committees early December, with a plan that it will be finalised early January and then socialised and shared early in the new year. So again, happy to take any questions on that emerging strategy, but it'll certainly come back to you in the new year.
Great, thank you. I can't see anyone in the room, and I don't think there's anyone online. So if we skip back to Joe, if you want to try again to
testing, can you hear me now?
We can. That's
excellent. I had to update my Zoom and clearly didn't get as far as the microphone. Thank you very much, Councillor Blacker and Simon. So if I can move to the next slide for the update around our performance. Back one slide, sorry. So A&E performance, we are for September running at 71.9% in terms of our performance, ranking 5th highest in London, and 12-hour waits at 96.1 against a 98% standard. I think the detail behind that, though, the issues for us are around our waits for what we call black reaches, but patients who are waiting in an ambulance outside A&E to be handed over at 60 minutes. Those have been significant issues alongside the volume and numbers of blue lights that we've been receiving. We're having higher levels of LAS than we've ever had coming through to Ealing. The volumes have continued to increase, including with our urgent treatment centre and streaming patients through to A&E after 4 hours, which adds to some of the challenges we have. And whilst we've had increased numbers of patients coming in, that includes some of our adult mental health and CAMS. This is not, and I just need to say this, just a reflection of Ealing, but also some of our patients from CNWL. So we are looking at patients needing to go across a number of our organisations for support for mental health input. But the slides you can see show where we're sitting at the moment around our performance against the national position. So we're over the line in terms of being green, but still we have more to do, significantly more to do. In terms of the next slide, please. We are, for LAS, this is a significant issue that we have been working hard on with our partners in LAS, because we have had challenges around releasing ambulances, and that impacts on the emergency response that they can provide to our population. In particular around resus. So we've been focusing on the handover processes we have and redirecting and having new schemes for that, ensuring that we have sight of everything that comes to the trust, including if they're on the ramp, and flow in order to allow us to offload as quickly as possible. So we have implemented a range of new standard operating procedures, SOPs, as we call them, but to support that. And there are 3 in particular, which I'll come on to, that we've taken forward. We have ongoing and daily review of all of the processes in place, both with LAS across North West London and within the ICS teams, regular meetings as well through the urgent and emergency care boards. And we are also looking at other mechanisms and tools that we can use, such as the REACH model, which stands for the Remote Access Emergency Coordination Hub. And it's a scheme that was run in London, the Royal London, looking at the ability to triage at source for patients to go to alternative settings other than to A&E. So we're looking at that as well. To the next slide. The impact around the standard operating procedures that I was talking about, and the 3 key ones that we've been doing a lot of work on, particularly this first one, the admissions against discharges. So what's commonly known as the Bristol model within health service, where we ensure that we are spreading the load and the impact of patients waiting in A&E across the organisation. And we do that by moving patients from A&E into a ward. The fittest patient, the patient's due to be discharged, sits out, and then the rest of the patient who is unwell comes in and goes into a bed, so that we get sickest patients into our capacity and into our wards. It helps reduce our ambulance handover time, and our team's been working hard to implement this. So we have scheduled flows of patients through the organisation 3 times a day, in the morning, at lunchtime, and in the afternoon. The other 2 standard operating procedures, one is with London Ambulance, which is a trigger that they can, if they have a critical patient come in that's being held in the community, they can trigger what they call a rapid release, which means that they will release a patient at A&E, which we will take but it's activated in extremis. And the other one is the ambulance cohorting, which we've marked out, and we have spaces now in our A&E where again, after 8 o'clock at night, if LAS are holding too many ambulances, we trigger, if they're being held for over an hour, they can trigger the release of vehicles where they will look after 2 patients of 2 vehicles and release a crew. And we have that operating both at Northwick and Ealing, and that's now fairly standard across healthcare. Other schemes that we have been working on have been, as Neha talked about earlier, was releasing additional capacity. We've actually opened 32 beds now. We have a rota working with the ambulance liaison officers, and we've also expanded home settlement support in the form of some of the capacity as well. I mean, Neha was talking about with the home and settle services started fairly recently, linked to our frailty STEC pilot that we're doing. We, at the moment on that scheme, have gone from seeing 20 patients a week. This week, we've running up to 40 patients that we're seeing. So we've nearly doubled our numbers. And we've got work as well with our partners in the local authority providing transport for us. And we're looking to link up with the care line team as well to provide devices for those patients who are vulnerable, maybe to falls, that we can provide more immediately and support them. We are also looking to expand our staffing, but as we sort of have outlined, that is an area where there is some risk in terms of capacity and working with partners across the system. And our social workers are coming back to work on site. That's a gradual process that's happening, but we are welcoming them with open arms to coming and supporting on site. And next week, we are going to be running a summit where we will be looking at all of these plans and looking at other opportunities and things that we might want to be looking to take forward collectively as a system across the borough-based partnership. Next slide, please. So some of these initiatives are things that we'll be looking at. So continued access to our community pathways for neuro and rehab and mental health, virtual ward support. So we've got virtual wards being established for respiratory, for heart failure and infectious diseases. And these would be for patients that otherwise would be in an acute bed in hospital and seeking to discharge. And our colleagues in Ealing Community Partnership are working around establishing 20 frailty virtual ward beds by Christmas. Mapping care packages against our winter peak demand, looking for restoration or looking to help support the restoration of step-up capacity on Magnolia and or step-down beds, working on early supported discharge around our fracture neck femur pathways, having re-established those after 2 years, and or provision of non-weight bearing capacity. And we're considering running some targeted MAID events for our known peak activities during winter as well. Next slide, please. I think just to summarise and to conclude around the fact that the difference this winter is some of what we would have done in past winters is to impact on our elective cases as we go into winter and as our emergency capacity ramps up. This year, that is not an option because we are catching up and we are committed to retaining our elective recovery and trajectory to ensure that we actually get back on plan to the 107% that we're trying to achieve against the 1920 baseline. Currently, we're at 98.1%. For outpatients, we have delivered 106 against a target of 97. And our outpatient follow-up recovery is only 1% off target. The news we have a bit more to do. Our 18 weeks, we have no patients waiting over 104 weeks, which is great. And we have 571 at risk of breaching 78 weeks, but it is reduced from 1,000 over the summer. So you can see there's been a huge amount of work going on to help bring these patients and get patients seen and to reduce this level of risk. There are 1,300 patients waiting over 52 weeks, but that is the smallest waiting list position. in the sector. And whilst we have 202 waiting over 62 days, again, it's reduced from the 279 only in August, and we're aiming to get that down to 161. We've ranked a top quartile for our diagnostics within 6 weeks. So we aren't able to utilise our elective capacity against this year's winter demand. So this is the challenge for us this year, in a sense of how we are balancing across the system and across the service our winter plans. I think that's it for now. If there's any questions, I'm happy to take questions.
Thanks, Joe. I can't see any, but Simon, you wanted to come back in.
Yeah, I was just going to say your question earlier around what happens if, what's the mitigation? What was there in those slides when Joe talked about some of the arrangements with LAS and some of the things about moving patients from A&E into a bed and some on the prospect of someone being discharged. Those sort of schemes are new this year, and that's what we're doing to try and make sure that the A&E department is not overrun, and we can offload the ambulances, and there's a range of additional mitigations there that are described there, as well as the expansion of things like the same day emergency care. So all of those things are what geared up to. And whilst Joe's right, we are trying to protect the elective pathway, but as I said earlier, in extremis, if patient safety is really compromised, we will have to look at that. That's the last resort, is impacting that elective path.
Great. Joe, Simon, thank you both. I don't think there are any comments in the room, or I can't see any online, so thank you very much. Hopefully when we have this conversation again in January, we will have not seen the electives being stopped, but obviously Kerry and the team at Ealing will be doing all they can to support you with bits of work that we can do around discharge back into the community. Anna, do we have any items to flag on the forward plan in terms of future, apart from obviously the big one in March?
Thank you, Chair. I'm aiming to get this into a neater place to share it. Apologies, it's a little bit fluid at the moment. In terms of our January meeting, we've got our Health Watch patient experience report from Daniel, and either in January or March, I'm hoping to bring back the COVID lessons learned report that we're doing on behalf of the Health and Wellbeing Strategy. There's been some delay due to various teams, just capacity, and we finally got our legal advice on it. And that's now been just being sent out to our teams on that and our partners. So I'll confirm that date when we have it. There aren't any other big agenda items at the moment for January, so we'll work with Health and Wellbeing board members to add anything in. March is looking very busy at the moment. So we've got Health and Wellbeing Strategy. We've got the new Council's annual Health of the Borough report, either in March or May. We can pin that down. And then a number, Daniel from Health Watch got a number of items in terms of patient experience, mental health care, home report and interim view, potentially, and also potentially a couple from our integrated commissioning team, an update, and the learning disability strategy as well. And similarly, a number already penciled in for May. Including potentially the Northwestern ICS strategy. I know there's formally a link for the Health and Wellbeing boards to receive that and align our strategies alongside it. So again, we'll pin down the date for that and then we can circulate it. But at the moment, January is feeling the quieter board at the moment. Thanks.
Brilliant, which hopefully gives our NHS colleagues some breathing room in January to cope with winter. Thank you very much, everyone. I don't think there's any other business, so